you very much, Sharma sir. Now we'll proceed with what LH hormone is and when and where we should use it. I really welcome all my panelists and my moderator, Dr. Megha, Malik. And together, I think we'll finish this journey in no time. So, LH hormone, looking at this history of IVF and looking at these pictures, looking at the destination of IVF, they remind us and they give us a hope. Looking at the Louis Brown, the first IVF baby in England, and Durga Kanupriya, the first Indian IVF baby, they give us a hope. And it is said, when destination is good, just forget about the journey. And sometime in IVF, we are really troubled by a tough journey, as shown in this sailor who wants to sail through, but he is falling in between and not able to sail straight to his destination. And sometimes the winds are so strong that he is stuck in between and he needs some extra help and extra ropes to sail through his destination. Or sometimes what happens that this boat is not able to go forward and just falling back again and again, and the sailor is same at the shore. So nowadays we see stimulation protocol is like stimulation is so difficult because we are getting older population. And the patient coming to us, to the IVF center, in such a late stage, getting multiple stimulation cycle for IUIs, for normal trial, for time intercourse. So it is really a difficult journey, but we need a magic to happen. And as the patient needs magic, we also need a magic, and there is a magic hormone, LH, which saves us in such a difficult situations. So scope of webinar was normal follicular genesis and control hyperstimulation that has been covered by Sir, and all the use in poor responder, more than age, hypo. So with this knowledge, I think we should quickly move to case presentation and case discussions. But we all know that main aim of stimulation protocol is to get good follicles. Multiple follicle development is the main aim, and not only the number, we need the quality also. If we get good quality oocyte, we get good pregnancy rate, and we are left with only two gonadotropin, LH and FSH. And we know what the role of LH in normal cycle, and there is no question. It has a very good role in normal follicular stimulation. But why we need in control ovarian stimulation, that is what Sir has told us. LH and FSH, they are working in a synergy. And I remember my UG days when we used to tell, my teachers used to tell us that FSH is like a chapati and LH is like a vegetable. You can fill your stomach with chapati only, but if you eat with vegetable, your food will be more tasty, more nourishing, more satisfactory, and it gives you more satiety. So that is the same story of LH here, and we are using it in optimal situation, optimal days, and optimal levels, and that is what required. All preparation we know, and now moving on to the case study. But we should be knowing the WHO classification of anovulation, and secondly, the Posident classification. I think everybody is learned over here, and I quickly move on to the cases. And I'll request my learned panel to just practical use of LH we should be discussing on. We'll not discuss the theory part so that we can finish it in time. All these slides Sir has taken. So nice of you, Sir. Thank you very much. Now I'm quickly going to first case. Dr. Neeru, I welcome you, Dr. Neeru. This is for the first time you are here. Neeru is my very good friend as well as my batchmate from MBBS SP Medical College. I really welcome you in DGF forum will we do. And this first case is to you.
Thank you very much. Yeah, thanks, Seema. And thank you very much, Dr. Shardajan ma'am and Dr. Poonam.
So first case is 30-year-old couple with infertility of 3 years, diagnosed with male factor in infertility. She is going for a first cycle of IVF. Her AMH is 3.5, LH is 3, FSH is 6, and our ultrasound 6 to 7 AFC in each ovary, weight 55, height is 155. So this is a normal patient with a normal ovarian reserve and coming for the first time to the IVF center. How will you stimulate, Dr. Neeru? What's your protocol? We just want to know what you are using.
Thank you, Dr. Seema. She is a normal responder patient, young patient. So I would like to stimulate with the recombinant FSH only. So I'll start, the starting dose will be FSH 225. And I will start antagonist, not in the fixed. I will do on the, I can do on the fixed also or mobile protocol also. So here, because she's a normal responder, so I will start using LH on the 6th day when I start using the antagonist.
So why we need to suppress with GnRH analog in a normal stimulation cycles? What's the need of GnRH analog here? Why we need to suppress them?
No, but I'm not using analog protocol. My favorite is the antagonist protocol because it's a patient-friendly protocol. So mostly I will use antagonist only.
So whenever we are using antagonist or agonist cycle, it is the concept is to just to prevent the premature luteinization of the follicles and prevent the LS surge. So at the one time we are just preventing the LS surge, and at that time to compensate for the low LH level, we are adding the LH here. So this is the basic theory why we use LH in the normal stimulation cycle also for IVF only. So we are at what we do in our center is we normally follow flexible protocol, and 90% of our stimulation cycle are NTEC cycle, and in this we use NTEC on day 6 or 7, depending on the follicle size and endometrial thickness, level of E2. And when we add antagonists, we normally add HMG on the 17th day to compensate for the low levels of LH, because we are not doing LH testing again and again. So this is what our protocol is. I request all my panelists, if they differ in something and they want to add on to something new on their part, Dr. Preeti, Dr. Jyoti and Dr. Aruna, if you want to add on something, please let us know.
This is the same protocol which even I'm using, Dr. Seema. For a normal responder, that is enough. You start with FSH, add HMG later on, and with antagonist protocol.
So basically, it's used in LH window concept, and this sir has very nicely explained. I think now we'll move on to case 2, and case 2 to Dr. Aruna. Welcome.
I want to add. Sir, want to add.
Madam, this lady has got a good AMH, and she's just 30 years old. So I might starting dose would be 150 IU, and I will to give a flare also with the say the 3 doses decaveptyl. So the consumption of the hormones, the cost will be reduced.
Yeah, I normally start with 187.5, and that is my favorite dose, and I think that gives a very wonderful result. So I don't know what's the logic behind, but I'm really fond of using 187.5 as a starting FSH doses.
So this ultra short protocol is normally we are using in the poor responder, especially when the AMH is very low. But it's good to listen that you are using a normal responder also, 3-day flare.
Yes.
Definitely consumption of doses will be less. But LS surge will be earlier if you are using a normal responder. What do you say, sir?
What is that?
Surge might come early if you are using a normal responder also. Flare protocol for 3 days Lupride in the initial 3 days.
The thing is that the flare would just decrease the doses of FSH. The number of days of stimulation would remain the same. So it will not decrease the number of days. So, but the only thing is the chances of OHSS will be less, and the secondly thing is that number of dosages will be less. But the spontaneous LS surge will not occur in these patients, and it will occur in that when you plan it that way only.
Okay, sir.
Thank you, sir. Thank you very much. Thank you, Dr. Neeru. And we are coming to case 2. And Dr. Aruna, welcome. And this case to you, Dr. Aruna. And patient is 31-year-old female, 21 BMI, previous history of 1 which was done at some other center. Man had a oocyte retrieval of only 4, and out of that only 1 was M2. Single embryo transfer was done on day 3, 1 into 6LB. Beta SCG was negative, and according to her, the stimulation was done with recombinant FSH followed by urinary HMG. And now she has come to you, and now on ultrasound, there is only 5 to 7 AFC. each ovary AMH is 3, LH is 3.4, FSH is 7.2, means she is also a normal responder by investigations. So how you will re-stimulate this patient because she is a hypo-responder for Syrian type 1 group 1 patient?
Yeah, Dr. Seema. So we know that this patient's fall in category of Poseidon 1. So a normal responder apparently, but landed up with a very poor response. So ideally the LH should be added in this patient for the in the second cycle. But one thing I wanted to say, if I have a history of previous stimulation, that will actually help me more. And also in our scenario, it is important for us to know where the first stimulation was done, what were the doses used, how long the stimulation went on, and when whether the recruitment was less or the later on follicles deteriorated, and also who did the pickup and what was the trigger. All those things we need to know. So once everything is clear, we know it was done as standard center by standard with the standard doses, and the person doing pickup was good, then we know the only option for us is to add recombinant LH in the next cycle. And in this patient, because she's a young one and the within reserve criteria is on the higher side, they're not very bad. So I think the adding LH from day 6 should be sufficient for this one.
So how you will proceed? You will start afresh, or you will wait for something, or prepare the patient for adding some adjuvants?
Adjuvant in this case may not have much role. It's more important in patients with more than 35. So I can go ahead with the next cycle straight away and start with the FSH and add LH on day 6. And if she, by any chance, if she has consumed more than 3,000 units of FSH in the last stimulation, then I would like to start recombinant LH from the day 1.
So can we avoid this situation in the beginning of stimulation? Can we do something, some test about to know?
We can check for the receptor polymorphism, but because this test is not really available, or it's expensive as well. So what we do, we increase the dose of FSH, add recombinant LH, and that is how we go. But if there's a facility, we can always check for the receptor pleomorphism, because if there's a receptor pleomorphism, the starting dose will be even higher.
Definitely. Thank you very much, Dr. Aruna. But what I used to do and what we are doing at our center is we are just taking the patient, considering all the factors, and considering that we've taken the good stimulation from good doctor and good retrieval was done, and good doses has been given. So we start adding LH empirically from day 1 of the stimulation with antagonist protocol, and we might get good result. But if we don't get result, definitely we have to look for the LH polymorphism. And I just want to speak few words about LH polymorphism. Here, as Sir has told us that FSH consumption is also more in these type of the patient. And these are the hypo-responder. They have a good prognosis because she's young, she has a good ovarian reserve. So they respond better. So whenever there is a hypo-responder, so we have two choices. Either we have to increase the FSH dose, or we should have to add LH. And mostly on day 5 or 8, when we see the eating level is not increasing and we are not getting the good cohort recruitment, so then we add LH and either increase FSH also, we get good results. So hypo-responders, they respond to good by adding FSH or by increasing LH doses. That is what we do normally. So
another point I would like to make, in such patients, especially in our country, when you get an unexpected poor response, you should always check for genital tuberculosis.
Okay, that is also a good factor.
Yeah, I have found that true in a few of my patients. I just checked for everything apparently normal, but when I checked for tuberculosis, the histopathology showed positive granuloma, gave them ATT, they responded better. So I think in our country, that point also to be kept in mind.
Yeah, the colored doppler of the ovaries would also help.
Endometriotic patient also, we should.
The colored doppler of the ovary, that will also help, because a patient who having poor blood flow in the ovary would require higher dosages. So that also is one of the indicators to decide the dosage for these patients.
Yes, sir.
Especially with the genital tuberculosis, there is a ovarian tuberculosis causing fibrosis. So you'll find that everything looks all right, but they respond poorly. So if you do the blood flow studies of these ovaries, then you can decide the dosage also for these patients. If the blood flow is less, more dosage required.
Good afternoon, sir.
And sildenafil and all, vaginally you can add sildenafil for these patients to improve the blood flow in the ovaries.
Good
I'll
afternoon,
request
sir.
my other panelists like Dr. Preeti and Dr. Jyoti to add on.
Good afternoon,
Sir, if you
Good
add Sildenafil, do you stop Sildenafil 2 days before ovum pickup?
Yeah, once you have achieved the levels, you don't have to continue
Yeah.
sildenafil. It is not that the patient will start reversing her blood flow if you stop the sildenafil.
Yeah.
Good afternoon, everyone. Can you hear me?
Yes, clear.
Welcome, Dr.
Yes,
Preeti.
yes.
Thank you, ma'am. Thank you. Ma'am, I would like to put forth a point that I would also think of starting long protocol in such a case. Maybe, and I would like to ask the opinion of everybody also, because I have done some cases where I found that they got less eggs and I did long protocol because although the
get
number
good
of days,
cohort.
the duration was higher, but I did get good results. That's a point which I'd like to make, yeah.
Yes,
And
yes.
Yes, we get good cohort. Sometimes we get good cohort, but sometimes
the uniformity.
yeah, but sometimes we need very, very high doses,
Very high doses.
and they even go in suppression. So we can give even initial 2 days antagonist 2 days, and then we can start the stimulation.
Yeah, Dr.
But yes, we have to rule out:
Sorry.
is there any history of tuberculosis, history of endometriosis, history of taking any steroid, or anything like SLE? They all things require higher dose.
Dr. Preeti, I would like to make a comment here. Like, if we are taking these patients for long protocol, we should have a look at the AMH and AFC as well, because
AMH
this
was
patient
very
has,
good.
she has got 3 AMH. She has got 3 AMH and AFC is around 14. What if she is hyperstimulated? Then we don't have a choice of changing the trigger. But in
Right.
our antagonist protocol,
The thing
it's
is,
very easy for
with
us.
the current strategies available for preventing hyperstimulation, luckily we have a lot of ways, and even with an
But in long protocol, we are
yes,
stuck.
but there are other things like hydrox, and she has an antral follicle count of 14, ma'am.
14,
So
yeah. And
maybe,
AMH
yeah.
is 3.
AMH is 3, yeah.
Yeah, in
But
long
she's
protocol,
got
many
previous
times we do
very
get what we
unexpected
see,
poor
we get
response.
more than that. So we should be prepared
If
for
she
that.
is poor and LH is not an alternative, then maybe I would think.
Yeah, probably, yes.
But actually, what Dr. Preeti is saying, I think it's very good because all the follicle, they will be synchronous, because asynchrony is also a very good cause of hyporesponder. So that is also a very good thing, just to change the protocol and get a good result. Thank you very
Or
much.
we can use stop protocol. We give the agonist stop on the day of the stimulation so that we can give any trigger.
Dr. Preeti, will you like to tell us about receptor study over here?
Sir has covered, but I would like to add just one thing. We know what is polymorphism, and it seems to be there in India, and we are all facing it. It's a change in DNA sequence variation, and just some variation which is common. They are both normal, but some patients seem to respond poorly. And sir has mentioned it, but we know Dr. Ramaraju, all of us know, who's done a study on LH receptor polymorphism, and he has studied that if you are able to identify those are the category of patients who require a higher dose of recombinant LH, and hence will give us more number of eggs and also better pregnancy rates.
Yes, I have done training at Dr. Ramaraju Center, and I'm just quoting what his result. And we used to get 3 type of result. One is A, second is AG, and third is GA. And if the report is A, that is absolutely normal responder, they don't need LH at all. And if the report is AG, A/G, then we used to add 37.5 LH. And when the report is GA, that is a very much required LH. And then the starting dose of LH was 75. So that Dr. Ramaraju used to do. And thanks to him, the time.
डॉक्टर एक बात बताइए, आप ट्रेंड हैं और डॉक्टर सीमा आप ट्रेंड है, तो आप करते क्यों नहीं हो यहाँ पर?
मैम बहुत महंगा है.
10,000 रुपए बता रहे थे वो तो.
मैम 60,000 के आसपास पड़ता है.
10,000.
मैम वो सैंपल वो तो खाली टेस्टिंग का सैंपल जाएगा विशाखापट्टनम और आएगा, तो वैसा बहुत मुश्किल होगा. हमें तो स्टार्ट करना है, उसी साइकिल में देखना है ना मैम. ऑन द सेकेंड डे हम भेजेंगे तो रिजल्ट आएगा, तब तक हमारी साइकिल निकल जाएगी. फिर नेक्स्ट साइकिल में एलएच का लेवल क्या होगा और कैसा रिजल्ट होगा. वैसे सर तो सबका यूनिफॉर्मली करते हैं, बट हमने अभी तक किया नहीं. वी डिडंट ट्राई. वी आस्क्ड हिम कि हम भेजें सैंपल, बट ऐसा ही लगा कि वी जस्ट चेंज ओवर द प्रोटोकॉल, चेंज द gonadotropin and just move on, and we get the result definitely. So moving on to the case 3. Thank you, Dr. Preeti, and I'll request Dr. Megha to take off.
Thank you, ma'am. So we'll start on with the case 3. She's a 37-year-old female with primary infertility of 4 years. her semen analysis. The semen analysis of the couple was normal. On ultrasound, AFC was good, 5 to 6. AMH was 2.5 nanogram per ml. LH level was 3.5 international units per liter, and FSH was 7.2. So her weight was around 57 kg. So how will you stimulate this patient? Dr. Neeru, ma'am.
She's an elderly, 37 years, even normal responder. So this patient, I would like to add some LH. First, I would like to give some adjuvant also. I will give dose of estrogen 4 milligram, 2 milligram BD start in the last cycle from day 21 so that I get the uniform cohort. And I would also like to give testosterone gel in the last cycle, in the previous cycle, not in the current cycle, and stop the testosterone gel in the current cycle. And then current cycle, I would like to add, either I like to give FSH plus HMG plus Luaris, or I will give only HMG. Better I can give only HMG also, because some LH these patients always required, because their LH receptors are inactive at some point of view. So I would like to add some LH in these patients. That change only I would like. Otherwise, I will give same antagonist protocol and flexible protocol.
Thank you, ma'am. Any other different views from any other? Because I think what we do is usually we start with the urinary HMG because of cost, the patient compliance and everything.
Yeah, definitely. We can start HMG also.
We can start HMG and plus testosterone or DHA addition prior to that. Like if patient has time, then 3 months prior addition is important. Whenever you start with the DHA, you need 75 milligram per day, and 1 to 3 months is required to see any effect for the better recruitment, or the testosterone gel prior to that recruitment cycle.
But Megha, this is a patient where the AMH is normal, the antral follicle count is normal. Why do we need to add adjuvants?
We don't need to. DHEA, Dr. Preeti is right. DHEA is to be added only if the AMH is less than 1.
Yeah.
Not for this patient.
This has she is 37, but she has all ovarian markers.
Parameters.
Iron group, 3. So
Her AC is only 5 to 7.
AFC is 5 to 7. We can give DHA also in the previous cycle.
In the field, if you read the requirement.
I will second Dr. Preeti's point that this patient is not for adjuvants because all her markers are in place. It is only age related that she is
yes.
So it cannot be for adjuvants. Adjuvants will be where the age factor is a younger patient and then the reserve is low. Yes, that patient would require a supplement like DHEA 6 to 8, 12 weeks prior to starting a stimulation, but not this particular patient.
Actually, there is a missing because AMH was written right.
Yes. If AMH is less, then we can give growth hormone also, but here we don't require all these things. Growth hormone
written wrong over there. It was Poseidon type 3 patient and her AMH was 0.8. Wrong.
Yes.
That was a patient, sorry. That was our mistake, yes. So coming to case 4, and the case 4 is for you, Dr. Preeti.
Doctor, we are confused.
Ma'am,
Present the case again. Whether it is 3.5 AMH or 0.8.
Ma'am, it's 0.8, it's not wrong recover. It is 0.8. And because the age was 37, her AMH was 0.5. It was just 0.5.
FSH was high 7, LH3 and AMH was 4.
Yeah. LH and FSH was normal. It was poor ovarian reserve. So it is Poseidon type 3 patient with age more than 37. More than 37.
In Poseidon type 3, adjuvant is recommended.
Age 35, less than 35 and poor ovarian reserve. That was a question. Age less than 35 and poor ovarian reserve, and then how you will stimulate the patient. That was a wrong, I think, some changeover is there. So, ma'am, अगर Poseidon type 3 है जिसमें poor ovarian reserve है, expected poor ovarian response is there, then we have to add on adjuvant therapy and we have to just be careful about the stimulation, how to stimulate that patient. That was a question, and I think there was some change of values while typing. So sorry for that. But agar ye less than 35 and with AMH poor, then we have to take this adjuvant in consideration and start HMG. Because her age is young, so we don't need to start on recombinant ones. We have to give urinary one and we'll get a good result with HMG only.
Adjuvant what then? DHES, one adjuvant, what else? We would,
In this,
Other-
we use DHES because she's a young patient. She'll respond to DHES for 3 months. And sometimes the patient less than 35, if AMH is less than like 0.03, 0.04, then we are using testosterone gel also. But I don't know what studies say. I think I'll take a help of you, Dr. Jyoti, if you want to elaborate on use of.
There are other things which I would just mention that we've been using. Literature does support, but I mean, it's not that concrete. Any major studies have been done. We are using the nitric oxide sachet, the RG Prime or RG Prime, whatever label brand you can use. And along with DHES, we also use wheatgrass powder for a long time in these poor responders as adjuvants to, then take up for stimulation. And then embryo pooling, of course, remains the counseling and the mainstay when we are stimulating these patients. Preeti, would you add something to that?
There are some studies.
We are also using CoQ in
coenzyme
Yes, coenzyme Q and wheatgrass
300 milligram twice a day.
for
I
6
have
to
used
12
for 3 months prior to stimulation in addition to DHEA. And there are a lot of studies wherein coenzyme Q is supposed to be the anti-aging molecule and helping in the mitochondrial improvement of the oocytes, anti-aging of the oocytes, also improving the oocyte quality.
Even preparation of DHES, which contains melatonin, has been documented by the literature that it has more role in these patients. So there are some preparations which are coming with melatonin also. CoQ10, melatonin, DHES, wheatgrass, and nitric oxide donors all have been labeled for use as adjuvants before stimulation. Testosterone gel we've discussed already.
But these preparations containing coenzyme Q have around 100 milligrams. There are a lot of studies which say
300.
the actual dose is 300 milligrams twice a day. And that makes it a very, very expensive option because coenzyme Q at a dose of 300, one capsule is 58 rupees. But still, I have used in some patients who were affording and
Yes.
to have any.
300 milligram capsule is also available.
Available, yes.
It is available twice as the dose, BD.
We use one out of either DHA and melatonin, or we use testosterone gel. So prefer will be testosterone gel if patient can use.
Yes, thank you. Just to conclude and just to avoid the confusion, whenever the AMH values are less and patient is young, whether she's young or whether she's older than 35, we normally want to add adjuvant, what all Dr. Jyoti and Dr. Preeti has narrated. So the interval or the preparation time is 3 months. And if we prepare the patient, we get a better stimulation. That is what studies are and what is our practical experience is. So that was a conclusion of case 3. Now moving on to case 4, I'll request Dr. Preeti to take over. She's an older female, last 10 years of infertility, poor ovarian reserve, showing 2 AFC only, AMH 0.8, FSH 12, LH is 7.2. So how you will stimulate this patient, because nowadays we're getting many patients of older age, around 41, they are remarried, they have a lot of babies. So they are coming for their peg only. And now the donors are also very difficult. So what we do is...
So before stimulating her, I would like to counsel her thoroughly. I would like to know the cause of infertility. Hopefully it could be a tubal factor or something which is not correctable and the male partner is okay. I would like to also have a look at the financial status. I would like to counsel her for duostim, for embryo pooling before I start, the role of donor, and after assessing her financial. If she is affording, then the ideal choice, I would like to use a combination of Rec FSH and Rec LH at a dose of 2:1.
Megha ji, please mute yourself. Satya Bansal ji, please mute yourself.
If she's affording, then I would like to use Rec FSH plus Pergoveris is available. Have used in very, very few selected patients with some good response, although it's too early because very small numbers have used. And then counsel her about dual stimulation and prefer an ANTAC protocol. And obviously, before that, we've discussed adjuvants, like all adjuvants. If she's not affording, then I would like to use HMG or mild stimulation or even minimal stimulation with clomiphene. And maybe I would also try the PPOS, the progesterone primed only protocol, wherein the cost can further be decreased with HMG and Clomid cycles. And obviously for duostim and then embryo pooling would be my strategy. Yeah.
Definitely, because in older patient, even the follicles are so less, so high dose of gonadotropin are not going to help them. So absence of follicles will not improve if we give higher doses. So our protocol is to start in a normal doses only, not to give 600, 650, 450. So we are not moving beyond 300, even if the patient's age is 40 or 42. So second is pooling of the cycle. That is excellent, because some patients, they are forming proper follicles when we are using the lower protocol like clomiphene and added HMG. And third is recombinant. Definitely they help better. They give a better oocyte quality, better M2 oocytes. And third is dual stimulation. Dual stimulation is wonderful for that, though we are not very happy with that. At our center, I request the panelists to throw some light on this, because we are not using dual stimulation, and though books say that in an older population, dual stimulation is very good, because they use the luteal phase stimulation or the second wave stimulation for the oocyte recruitment. So if anybody is doing dual stimulation, we'd like to have that knowledge also.
Dr. Jyoti, I have used dual stimulation few of my patients when I was not very happy with the result. I rather found using long protocol with fresh day 5 transfer better in these patients. With milder stimulation, say Letrose in the beginning, then add on HMG or Pergoveris depending on patient's affordability.
But Letrose would give only one follicle.
Yeah,
I'm sorry.
Hormone addition is
Letrose would be monofollicular development. We're talking about
No. We are starting with Letrose and Pergoveris. Starting with both, so that there's some endogenous FSH-LH as well and some exogenous. So in these kind of patients, this protocol also gives you, because Pergoveris is very expensive. If you add Letrose, you can slightly reduce the cost.
Although I would like to add one thing. In duostim, somehow the concept of duostim is very bad. Stimulating a lady in a month for 20 days, 20 injections, except only if the patient has come from far. I would never do duostim, because I think it's not female friendly and it's too torturous on the lady.
definitely.
Sometimes when you have to do it for oncology,
the same number of injection, better start at fresh and then give the injection and get a thing. But though in the books they have given, and many studies are also there, and many people in IVF, this group, they are using it. But we are new to that, we are not using, and we have used 2 times, but we were not happy because we were not able to recruit many of the oocytes. So this is concluding the 4th case, because older patient. Sir, yes, sir, please.
No, I don't think it's time to throw the dual stimulation into the dustbin. It is important, because see, these patients are expected to have less number of oocytes only. And what you see is that the first stimulation, when you give it, you may get, say, 2 follicles or 3 follicles, and the quality of the embryo which will form, say you may get some amount of fragmentation in that. But if you stimulate, continue stimulation again, and when you do it, you find that the quality of the oocyte is better. What is the reason? Because when we are doing the first pickup, we are making a small injuries of the ovary with the help of a needle, and some growth factors are produced over there. Now those growth factors give you better quality of the oocyte second time than the first time, and the number also maybe increase 1 or 2 more. So like I have been using dual stimulation in patients. The first cycle I may get only 2 oocytes, and out of that one may be M2 and one is M1. While when I stimulate second time, I get say 3 or 4, and all of them are better than the first quality. So I try to rationalize why it is happening. The same patient, same medicine, same this thing. So I think this is growth factors which are improving the chance of getting a better quality of the oocyte in the second stimulation. So this is my personal experience. I thought I'll share with you.
Thank you very much, sir. Thank you very much.
Second part, this egg quality and the number will be better. What is your protocol of stimulation in such cases?
Madam, you're using the antagonist protocol, and after the pickup, the next day onwards, you start putting the MP8 10 milligram twice a day, and on day 3, you call the patient again, and by that time, you know the quality and numbers. You already know the oocyte, the quality you know. If the quality of the embryo is good, only in that patient, I would give the double stimulation. If the patient is already having fragmented embryo on the day 3, I know that this patient will not be benefited by double stimulation. So I will tell her, okay, sorry, now you should go for a, donor egg only subsequently. But if you find, even if I get 1 or 2 good embryos on day 3, then I would start the stimulation, continuing with the methoxyprogesterone acetate. And I find that I get 1 or 2 extra oocytes, and the quality also is slightly better than the first one, retrieval. So you have to also learn that you may have to stop the double stimulation at the first time looking at the embryo. So that also one has to convince the patient. Not that in the first cycle I get 2 or 3 oocytes and all are grade 2 or grade 3 embryos. There is no point giving the double stimulation to this patient.
Sir, but in cases where you plan a dual stim, don't you give the first follicular phase trigger as a GnRH agonist?
Yes, definitely.
No, in these patients, you can give SCG also, you can give double stimulation also.
What do you prefer, a dual trigger? Because SCG...
Dual trigger in follicular phase.
Yes.
Yeah, we give dual, once follicle size is reach 18, so I'll give both decapeptyl-2 injection and SCG, recombinant SCG along with that.
So if we are given dual trigger, HCG we are given, then we always give antagonist 3 injections to have quick luteolysis, because HCG effect will last for so many days. Otherwise, if we are given only agonist trigger, then we can start after 2 days without giving antagonist also.
Yeah, they say you have to give gap of 5 days then. If you are using SCG.
If we give HCG, yes. And we need antagonist also to have quick luteolysis in these patients. How many days gap you give if you are given dual triggers, sir?
No, so at least, at day 3, I will assess the patient's embryo and then only start the stimulation next day onwards.
Yeah.
If the embryo is not good quality, I will say, okay, we'll stopping that, we are not, going ahead with the double stimulation.
And you are adding recombinant LH in all these patients or HMG?
HMG.
HMG.
Thank you very much, sir. Thank you. And now we are coming to the last piece of today's webinar. And I request Dr. Megha to take on.
Thank you, ma'am. So this is a special case. She is a 8 years old female with normal BMI, weight approximately 56 kg, married since 3 years. Her HSG was normal. She received multiple ovulation inductions with tablet letrozole 5 mg and the time intercourse. 2 cycles of 10 days for allotropic stimulation was also given, and IUI was done at some other center. In both the cycles, ovulation was documented at day 15 and ET was normal. Now patient came to us for IVF cycle. Her estradiol on the day of the trigger was never beyond 50, as patient reported in the previous stimulation cycles also, the normal stimulation cycle. Now on ultrasound, the AFC is 3-4 in each ovary, and the AMH is 0.2 nanogram per ml, FSH is 32 international units per liter, and LH is 17 international units per liter. And E2 is 45 on second day. How will you stimulate this patient? What is the diagnosis? And how will you stimulate this patient? Imam, you can answer this question.
Megha, just tell me, FSH, how much did you say?
32 international units per liter.
32.
Yeah.
I will repeat FSH because this looks like a case of going into ovarian failure. Premature menopause.
Tested this. Previous reports she had, 2 to 3, they were the same. High FSH, LH, and E2 never beyond 50, even on the day of the when she was ovulating.
Her menstrual cycles,
they were regular.
It looks like a
not 25, 27, but they were regular. They were normal cycles. She was menstruating. So this is a special case basically.
FSH is a late marker though, but it looks like a case of premature ovarian failure going into POF.
Yeah, into POF.
So I would counsel this patient, maybe sometimes they don't agree. You repeat this value of FSH, try to counsel this girl. If they don't, then give a stimulation of 4 days, and 5th day, if there's no response, it will land up into cancellation, what you may do. And after which, she has to be counseled for priming with estrogen plus progesterone and then taken up for an OD cycle.
Yeah, ma'am. Actually, this is a special case. I just wanted to discuss with you, even need your opinion.
I feel the menstrual history, sometimes they don't come and give the actual history. I've had patients like this, married, they don't tell that, they will say only after marriage my periods have become irregular, where the history will be lying before marriage. They know that the problem is existing, but the parents have got her married, and when you take them into the ultrasound room, you go into the deep history, tell. She'll say, no, I used to bleed, but sometimes I used to take medicines and then bleed. Then there are cases, diagnosed cases of premature ovarian failure, which they are not able to accept because there were social reasons for that.
I think we look at
FSH of 32, I am sure that menstrual history is wrong.
Yeah, you're right. This patient was not ready for the donor cycle. She came to us 2 to 3 years back. Like, we told her that your AMH is getting low, you have to get 5-year, but she didn't. She went to other centers, she get an IUI cycle and all that. But what interesting, we felt that we stimulated the patient because she wanted to get stimulated for herself only.
You do it for her satisfaction, and then there's no response.
But we got the embryos.
Yeah, we got the embryo. She's pregnant now. She's
Self-embryos.
Either the FSH is wrong or the history is wrong. Either of the things are missing there.
We got them repeated. Then we did the E2 was not beyond 55 on the day of the trigger also. After D17, we had 4 eggs. But the E2 was not 50. She said previous reports also it's never beyond 50, but you do the pickup. I am ready for it. Whatever the result is, I want to get the pickup done for myself once. So we did the pickup and we got that embryos. 2 embryos were made. And then we transferred that in the next cycle, and she got the result. Like, wow.
Then you label it as a miracle.
That's why we just wanted to present this case. That's
just wanted to say that never lose hope, and there are miracles, they happen, and we have to at least give one trial of stimulation, definitely to each and every patient, those who are requesting for their own eggs. So this is what we want to say.
One thing, I think the second time we stimulated her because she wanted that you can make more eggs for me because I'm ready for it. But I think HMG adding in the second stimulation again, maybe as sir recommended that there is some receptor, you can say the blockage of the receptors due to high LH, urinary HMG dose. So second time she didn't stimulate it well. We had to cancel the cycle. There was no response at all. But we transferred what the embryos we made in the first cycle. And so we got pregnancy with that in the very first cycle.
Which is 4 months pregnant now.
Good.
So, coming to the end, I think we have...
I think we should conclude now.
Sir, you also get this kind of miracles? I have never got miracles like this.
Yes, ma'am.
I haven't got it, ma'am, in 12, 13 years. Something either the report is wrong.
Miracles do happen, madam.
Definitely.
And I have seen
present that case, ma'am, because we have all that.
So many years, I had seen Madam one. Patient was hypo, such small uterus, and then we did her IVF and she didn't conceive. And then the patient was sent to home, and after 1 year or so, we came to know that she became pregnant herself. And FSH was like 50s. FSH was like in 50s, ma'am.
Actually, miracles do happen, but they don't happen every day. I've also seen... I have seen one patient.
I think if you bring it for a case discussion, these kind of things don't happen.
Yes, these are miracles. They don't happen every day.
They don't happen.
Ma'am,
what is your...
Not every day.
Anybody who
So what is your gonadotropin of choice? What is your gonadotropin of choice in obese patient, BMI more than 30? Do you add LH or give HMG or give only FSH? If BMI is more than 30, young patient, age is 30, AMH2, so how you will start stimulate this patient? Do you take LH consideration in obese patient also?
सर आज एलएच की बात हो रही है तो आप हर एक केस में एलएच फंसाओगे.
No, the thing is, I just want to tell her, Dr. Neeru.
Let's talk about.
Yes, sir.
We've been also practicing for a long time. LH is a new story, and what Dr. Brigadier Sharma has said that this opens up an area. Try it out. But आदमी left and right use करता है, ऐसा नहीं है भाई मैडम.
No, the thing is, the obese patients, the problem is their fat. The response is not coming because we are giving injections subcutaneously in the fat. So, it doesn't give you a sudden rise because all these gonadotrophins act only when they, the peak is there. So, you should select a site of injection for these obese patients. Don't give it on the abdominal wall because that is the, the thickest fat over there. Give it in the forearm or give it on the thigh where the fat is less. You'll find that response will be better in obese patients. Because if you give it the abdominal wall, so you'll wonder why I'm increasing the dose and nothing is happening. The reason is same, because the fat, the blood supply is less, the gonadotropins remain in the fat for a long time. It doesn't form a peak, it forms a plateau only. So with the result, the response is poor in these patients.
So thank you very much, my panelists, ma'am, co-moderator, and my expert, Dr. Sharma sir and Shada ma'am, and Dr. Poonam Goel ma'am. Thank you very much for this opportunity. And I think it comes to the end of LH use. But we are using HMG more than recombinant because it is pocket friendly, cost effective, and gives almost same results. This depends on the convenience, but we are using each and every patient, and we have a very good experience of HMG. And we sometimes didn't get the result in recombinant one, but if we change it to HMG, we really get the results. So that is what I can say, and thank you very much.
I think we conclude the session for today, and the inference is that the LH should be used judiciously, and we should clearly understand when and why we are using it. So I think we had 75 plus attendance today, and that was very great. My thanks to delegates, all of them who have joined us today. And great thanks for the sir. Sir, you had done a great job today. Thank you very much, Sharda ma'am. And thank you very much to Dr. Jyoti Bali, our today's guest, Dr. Neeru, Dr. Preeti, and Dr. Seema, and Dr. Megha, and Dr. Aruna.
Thank you.
So thank you very much.
Madam Preeti kahan se hai?
Thank you.
Ma'am, Dr. Preeti is the one who inspired me for IVF study. She started with me only, and she is the one who made me study IVF. So thank you very much, Preeti.
Thank you.
Hai kahan par?
That is a part of All India. And we have our own center in Paschim Bihar.
Ma'am, West Delhi mein.
West Delhi में center है इनका अपना, my name.
And she's very good at studies. And Sharma sir, you remember our days? We used to call each and every day. And सबको बुला के लाए थे, sir, granulation आ रहा है, sir, ये हो रहा है. We used to trouble him a lot. Thank you very much.
It's always a privilege. It's always a privilege.
But my at the last minute, I just wish to tell you, today we have discussed LH. You can take it across. You can take a Google questionnaire from people. How many people are using LH? And people like me, there'll be many people like it. So don't get with an idea that left and right you'll be using LH.
Yes, it has to be used very judiciously.
Oh yes, it has to be used very judiciously.
Very judiciously.
And for anything, when you come on a panel, you have to see to it that anything which you're telling should be evidence-based. कोई कुछ use कर रहा है, कोई कुछ कर रहा है, it's not possible, madam.
So thank you very much.
Thank you very much.
Thank you.
Thank you all. Thank you, sir, again.
Thank you, ma'am.
Thank you, sir. Thank you, sir. Thank you.